Ladies and gentlemen, good morning. It is an honor to be here for me on the kind invitation of Dzinich, and I've been requested to talk about coronary emergency surgery in Hungary. Professor Otto told the most indications about the same topic, so I tried to skip some indicational slides. Emergency coronary bypass surgery represents a unique and a high-risk population, which is challenging today also to the cardiac surgeon and even to the cardiologist in the decision-making. Emergency CABG is defined as surgery within 12 hours from the event resulting in the hospitalization. And the reasons for emergency surgery are either anatomic, morphologic, or unstable symptoms after the catheterization. Patients who have recurrent angina after catheterization are usually admitted to the cardiac care unit and referred for urgent surgery within 48 hours. The acute coronary syndrome is divided in three groups, which is STEMI, non-STEMI, and unstable angina. The rapidly evolving guidelines, which has been shown by Professor Otto recently, states the management that should be based upon a system of risk stratification, incorporating and assessment of chest pain, ECG changes, and cardiac markers. We saw also previously there are limited indications for emergency cardiac surgery. The most frequent is the bailout phenomena of the catheterization, which includes ostial left main stenosis, other PCI complications as shown here, like coronary dissection or perforation, acute stent thrombosis, or unstable symptoms with hypotension, dynamic electrographic changes, or arrhythmias. In our institution, the mean age with the aging population, it has increased from 62 to 64 years. Similarly, the prevalence of triple vessel disease, left main disease, peripheral vascular diseases, dyslipidemia, and hypertension gradually increased. In comparison to the patients who have elective cardiac surgery in comparison to emergent cardiac surgery, we can see this is stratified for 2 decades, and this figure comes from the Toronto Hospital. We can see the decline of emergent cardiac surgery in the last decade, as in many centers, cardiac programs use PCI exclusively for emergent acute coronary syndrome treatment. However, in these first decade, we could see that the long-lasting effects of PCI is not perfect, so we have some increase in numbers in the next decade. What is very interesting, however, we don't have such a volume like Professor Otto shown us. We have in Hungary maybe 9 million people with about 27 cath labs. But it is very interesting that all those numbers, what we see from the United States, probably 5 or in 10 years, we produce the same curves and same data as it was 10 years before. The current trend for PCI and CABG, it's straightforward for PCI because it's very feasible and safe to do so, and quick and convenient with the pretty low risk, which is interesting that in CABG it favors with poor LV function, but with extremely poor LV function, it favors to PCI. Even in the presence of serious comorbidity, it favors to PCI. Indeed, recent trial data support that the safety and the efficacy of PCI versus CABG for patients at high risk for CABG. The second pragmatic factor affecting the choice of percutaneous coronary interventions over emergent surgery is the constraint that in many centers, upon the resources available for surgery, particularly when scheduling urgent operations, it is logistically generally easier to proceed immediately with the PCI at the same sitting on the table as the angiogram than to wait for an operation. However, this made cardiac surgery very elegant and convenient because we hardly work at night. There are limited surgical indications, which was mentioned previously, and the mortality risk associated with surgery after AMI remains controversial. The primary isolated CABG is about 8% with acute coronary syndromes, and out of these we have 40% of angina, 42 with non-ST, and 18% with the ST elevation infarction. We have risk profile variables which affect heavily and influence the late outcome, which is age, NIHA, functional status 3, low ejection fraction. COPD is an extremely hard influencing factor. CVI and the preoperative catecholamine and preoperative cardiac shock is the most influencing factor of late outcome. Electric and renal disturbances, and whenever additive Euroscore is over 10 or the syntax score is high. The timing of surgery is key issue in the decision-making process and the late results. The average time this is an institutional report, was between symptoms and surgical intervention for angina and non-STEMI from 12 to 19 hours and 13 to 17 hours respectively. In patients with STEMI, the time interval was 5.6 plus 3 hours. In addition, that STEMI revealed a different pattern of influence of the time elapsed between MI and surgery on perioperative mortality, which was significantly different between survivors and non-survivors. The surgical management. The operative procedure was performed either by means of cardiopulmonary bypass or an off-pump procedure. By myself, I sometimes do cases on pump, but on beating heart, because I have the impression that such a broken heart does not have enough coronary reserve capacity to restart the heart. Sometimes we get the patients with mechanically supported balloon pump. And in case of on-pump surgery, the myocardial protection was obtained with antegrade crystalloid cardioplegic solution. However, I think that blood cardioplegia has more advances. The decision regarding the applied surgical technique was left to the operating surgeon. The operative data did not differ between groups in regard to their CPB and aortic cross-clamp time and the reperfusion time. The total number of bypasses and the use of the mammary artery for grafting were similar in all groups. However, there was a statistical difference in the use of inotropic drugs and IABP balloon pump between the groups of STEMI and non-STEMI over unstable angina. Age, functional classification, ejection fraction, and catecholamine support cardiac shock, it was mentioned previously, they are predictors of operative mortality, and independent predictors of operative mortality is hypertension, previous coronary artery, bypass grafting, extremely poor left ventricle function, and congestive heart failure. We can tell that CABG in patients with acute coronary syndrome can be performed with good clinical results. The clinical outcome is particularly depending on the different groups of the acute coronary syndromes. Therefore, an individual risk stratification of each patient is necessary. The time interval of the golden 6 hours seems to be crucial as a prognostic variable in the STEMI group. Probably we can predict some future, which is the pace of change and advancement in the techniques of revascularization for acute coronary syndrome has never been greater. It is therefore important that the optimal treatment for such patient is decided by a heart team, the communication is extremely important between cardiologist and heart surgeon on site. We can be sure that the majority of patients with acute coronary syndrome will benefit from two complementary strategies that continue to advance and improve. If drug-eluting stents and total arterial and OPCAP deliver sustained long-term results, both forms of revascularization will gain in safety and efficacy. There will be a continual substantial expansion of PCI, and with respect to the coronary artery bypass grafting, there is likely to be a continued but more modest increase in numbers generated by patients with patterns of disease unsuitable for PCI, and by those with coexistent valvar and aortic disease. Thank you very much for your attention.
Thank you very much, Mate. We are moving on because we are in a hurry. If there are some questions to Dr. Dzinich? No, thank you.
Thank you very much.